Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Julia, 40 years old, female with episode of dizziness. Take history, examine her, and address the concerns. Yes, here you go.
Mhm. Hello, good evening. I'm Dr. Musa, doctor in the clinic today. Let me confirm you are Mrs. Julia, 40 years old.
Yes, yes, I am, doctor.
Mhm. Okay, Miss Julia, we are here to discuss about your medical condition. Is it okay with you?
Yes, of course.
So, can I know what brought you to what brought you today to the clinic?
Yes, actually, doctor, I have a long history, but the thing is, my husband forced me to come to the hospital because when I really was abnormally dizzy today and also yesterday. But today is worse.
I'm sorry for that, Miss Julia. Miss Julia, it is the first time you have this
Yeah,
dizziness?
yeah. These are the first time. Today is worse than yesterday.
So, what do you mean about dizziness? You lose your consciousness or you just dizzy?
I was about to lose my consciousness. I was about to faint, and it was something that was short lasted. Like it lasted only 3 minutes,
Okay.
almost.
I'm sorry for that, Mrs. Julia. Miss Julia, what were you doing exactly when you have this dizziness? You are
I
like,
was
mm,
I was sitting chatting with the family after lunch.
you are sitting or you are standing?
I was sitting.
Okay, sorry for that again. Okay, do you have any? Do you see any abnormal vision before this dizziness, or you smell any abnormal smell?
No, it's fine.
Do you have any racing heart before this smell?
Of
Before this?
course. Yeah, of course. It was, I had, I felt my heart is beating fast, and I felt that dizziness, and also I was very weak and sweaty.
Any chest pain with this racing heart?
There is no chest pain.
Does this associate with any feeling sick or being sick?
Yes.
Okay, I'm sorry for that. Did you measure your blood sugar during these episodes?
No.
Did you
No,
check?
but the ambulance told me it's fine.
Did you check your blood pressure?
Only in the ambulance.
It was normal.
It was little high, they said, but it's not low.
Okay. Okay. During the episode of dizziness, do you have any loss of consciousness? Did you lose your
I
consciousness?
was about, but I didn't.
Okay. Did you have any? Did you notice anyone notice your limb are jerking?
No.
Okay. How's the attack? How does attack end? You take some fluid or you take some sugar?
No, I didn't take anything. It went the first one. It resolved on its own the day before, but the next day when it came again, we were feeling that we need to come to the hospital immediately. So it also resolved on its own. I didn't get anything.
Did you get your consciousness? Did it recover completely?
Yeah, I just tried to relax as much as I can, and then it recovered. Yeah.
Okay, sorry about that, Mrs. Julia. Did you notice that you with yourself? With yourself?
No.
Did you bite your tongue?
No.
Okay, apart from this dizziness, do you have any history of weakness? Any weakness in your arms or leg?
No, but I actually feel I feel also weak over the last. I was feeling over, you can say, last 2 weeks. I was feeling weak.
Any numbness in arm or feet?
No.
Numbness or tingling. Okay, did you feel unsteady? Any loss of balance?
No.
Did you have any
No.
vision problem?
No.
Any headache?
No.
Okay. Did you have any long-standing disease should be aware?
No, I don't have any medical conditions.
Mhm. Okay. Now I will ask you some general question if I can. Do you have any tiredness recently? You feel tired?
Yeah, I told you I feel tired over the last 2 weeks.
Hmm. Any specific time you have this tiredness? More at the night,
It's all the day and night.
all of the day. You have any difficult breathing?
I get short of breath when I exert and walk, and that's happening over the last month also.
Hmm. Okay. Do you have any history of high blood temperature?
No, but I
Any
get some night sweats actually over the last 2 weeks.
mhm. Okay. Any weight changes recently? Sorry.
A slight weight change loss, like not something, but I didn't measure myself. But it's something like you can say 2 to 3 kilo.
You feel.
I think
Mhm.
over the last 2 weeks, yeah,
Is it intended?
or one
This loss
month.
weight? Is it intended? This loss weight?
No, 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 it's not. It's not. I no, eat normally.
Uh, okay. What about your appetite? It is normal. You said that.
Normal, yeah, yeah.
You told me about you have a sweating, night sweating exactly. Yes.
Yeah, it's like a slight sweat. It's not that drenching or something.
Hmm. Hmm. Okay. Any difficult breathing on lying flat?
That's happening over the last actually 2 to 3 days. Yes.
Okay. Any difficult breathing awake you from sleep, searching
Yes,
for air?
yes, yes. Over the last 2 nights, I couldn't sleep. My husband noticed, and I woke up.
Hmm.
Yeah,
Any swelling in your leg?
yeah, I got that also the last month. I noticed ankle swollen. Yeah.
Okay. Do you have any cough?
Yeah, I have actually cough over the last month.
It is dry or is phlegm?
It started dry, and just over the
Mm.
last 2 days, it's now there's. I feel there's something.
Yes, phlegm. Mhm.
Mm.
Do you have any noisy chest?
No noisy chest. No,
Do you have any tummy pain?
no tummy pain. No.
Any change in your bowel, like loose motion or hard motion?
It's hard actually. It's hard. Yeah, I have noticed this. It's hard, getting hard. I don't know why. I'm getting laxatives trying to make it easy.
Sorry about that.
Mm.
Okay, any change in water work, like increasing amount or frequency?
Yeah, yeah, yeah. It is increasing actually. Increasing also.
Okay, okay. Apart from that, do you have any joint pain recently?
Yes, doctor, you are asking good questions. I have actually, I've noticed my knees mainly and elbows.
Mm,
They sometimes get swollen.
mm-hmm,
I went to the GP. That happened with me 2 times before, and he gave me some steroids and
mm-hmm,
just short 5 days, and then that's it.
mm-hmm.
Yeah.
Which joint? Your knee? Your
It's
toe?
my left elbow and my left knee. Yeah.
Okay. Any morning stiffness in these joints?
No.
Did you notice that it is the pain increase with movement or during rest?
It's get better with rest.
Better
Sorry,
with
it gets better
mm,
with then I will move.
when you are moved. Mhm.
Yeah.
Okay. Do you have any rash in your body?
Russian. Yeah, I have the in my leg. I can show you.
Okay.
Um, you can ask. I'm actually I didn't prepare the image. Sorry. Yeah.
Okay. Okay. When it started this rash?
Not sure, but I just noticed it.
Okay. It is scaly. These scales in this rash.
It is healing, you can say, yeah. Oh,
It is
it's not
healing,
scaling, no. Oh,
not
it's healing,
scaly.
yeah, 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 yeah.
Scaly. It is
Uh,
itchy.
I don't know.
Okay. It is itchy.
It is itchy, yeah, you can say.
It is
I will show you
oozing,
now.
oozing blood.
I can send in the group, right? Okay.
Blinchable or not?
I don't know.
Not to know.
Oh,
When
you
you
mean examiner?
sorry. When you press no. When you press in the slash, it disappear.
Uh, I'm not sure.
Okay. Okay. Uh, okay. Do you have any these spells? Listen. Sorry. You have any this spells? Any dizziness when standing from sitting position?
No,
Any user preference?
no.
Can I know what's your medication list?
I'm not on medications actually, doctor. I don't have pass.
Any over the counter drugs?
Just paracetamol and ibuprofen.
How frequent you use this paracetamol?
Just when I need.
Any family history of any gland problem or any cancer?
Oh, yeah, yeah. I don't have cancer or gland, but like my family have very strong heart disease.
Mm-hmm.
There is open heart surgery in
Mm-hmm.
my mother, and there
Mm-hmm.
is my brother died from at young age. The
At you,
doc, they told us he could be having heart disease. We don't know. Like at
mm-hmm.
he was at 15 years, he died suddenly.
Mm-hmm. Mm-hmm. Sorry about that. Sorry for your loss. Okay, what do you do for a living?
I'm farmer. I work in farm
You
all
are
the time.
you are farmer. How much symptoms impact in your job?
Really now I'm very tired over the last month.
Mm-hmm. Okay. That I am okay. Okay, absolutely for that. I have to diagnose you and give you suitable treatment.
Yeah,
Now I examine you, and during
yeah,
examination, I will ask some question. First, I will go to the hand to see
yeah.
if there is any leukonychia or kelonychia. And this,
No.
okay, then I examine. I need the observation chart of the patient. I need blood pressure, sitting and standing.
Okay,
Mm,
okay.
blood pressure, sitting and
Well, the
standing.
blood pressure is on the higher side, 160. Well, sitting and standing is there's no drop, but it's on the higher side, both 160 over 90. A heart rate on the higher side, 90, and
Mm-hmm.
saturation and respiratory rate are normal.
Blood sugar.
Normal.
Normal, okay. Then I will go up to see if there is any proximal myopathy, and then I will go to the eye to see if there is any
Positive.
the eye, any redness, to see if there
Proximal myopathy.
ah
Any redness. Um,
any redness in the eye,
no,
any pallor,
no, no pallor.
okay. Okay, then open the mouse to see if there is any cyanosis and go direct to the chest and the heart. First, I will do.
I
I
think
will
2 minutes now.
yes.
Heart is
I
irregular. Irregular.
okay. I will go to the first aortic area to see
Irregularly irregular.
irregular.
There is no murmur you
No
can
membrane in the aortic
find.
stenosis.
No,
Yes,
no,
okay, and
no.
then okay, and then I will go to parasternal, the left parasternal area to see if there is also murmur of Hockham. And
No.
okay, and then I will listen to the back of the chest if there is any fine basal crepitation or
There
coarse
are
crepitation.
bibasal crepitation, where
Mhm.
also you need to listen.
Yes, in the apical.
Yes, there are Velcro crackle.
Okay. Okay, then I will go to check the rash in her leg, and I need the rash. I will see if it is painful, and also check the
It's
movement of
not
the
painful.
not painful
Movement.
movement
Movement of foot.
of the joint.
There is some effusion you feel,
Mm.
and it's slightly hot. The left joints, the knee and ankle, elbow,
Mhm.
but it's not
Okay.
restricted.
Okay. And then I will do pronotor drift. I end my examination with pronotor drift
Negative.
negative and ask Mrs. Julia. Mrs. Julia, can I know what's your concern?
Doctor, can this be related to a medication that I took? I'm sorry, embarrassed. Took some little party injections in my young age. Could this be after that?
Oh, I forget to ask about party drugs. Yes. Okay. Ms. Julia, I appreciate your concern, but I have few possibilities. First, we have to exclude any heart causes of this dizziness, and also I have another possibility. It might be a disease called sarcoidosis. Don't bother the name. It is a disease of defense system which attacks the joint and also cause increase in some salt in your blood called the calcium. So what we need to do now, I will admit you in the hospital and doing some scans to the heart and doing some blood tests, and we will have another meeting to discuss the result.
Okay. Okay.
Okay, time's up.
Thank you.
Questions.
It is
Yeah.
combo case, Dr. Abdullah. Okay.
I'm sorry. Yeah, but so give me your differential diagnosis.
Yes, first, my differential diagnosis, it might be due to first, I need to exclude the cardiogenic dizziness, so I need to do ECG and echo, and also Holter to exclude arrhythmia. Number two, I forget to check the lymph node. So number two, maybe sarcoidosis.
Okay. Yeah, there is cervical lymph node here. Yeah.
So I need the number one will be sarcoidosis, and this sarcoidosis infiltrate to pituitary, causes dizziness, or maybe due to hypercalcemia causes dizziness. So and number two would be arrhythmia. Number three. Number three, maybe neurogenic cause. Also, I need to do CT.
Yeah.
Okay.
But the pulse, how was the pulse here? So you have a diagnosis here. So there's
yes, the positive finding will be yes. The pulse is atrial fibrillation.
Yeah.
Okay. And also there is fine basal crepitation. Maybe fine basal crepitation, and also there is patient in heart failure. What also this axial lymph nodes, there is polyuria plus constipation.
Okay.
Symptoms of hypercalcemia. Yes.
So how you will investigate this patient?
Yes, first I will admit Miss Julia. I will do basic investigation, CBC looking for any anemia or any infection, CRP, ESR, serum electrolyte, sodium, potassium, calcium, and also investigation for the cause for the heart. I will do ECG, echo, X-ray, and also Holter for fear of arrhythmia. Yes, and also blood sugar and the CT to exclude any neurogenic cause. Less likely visual hypotension. Only that. And yes, urine culture, and according to sarcoidosis, I will do ACE level. Calcium and ACE level.
Okay, how you will manage?
Yes, and the Doppler. Okay, apart from non-pharmacological patient education and counseling about her condition, I and also multidisciplinary team of cardiologist and also pulmonologist and neurologist, and
who
then
also you will include
neurologist, yes, neurologist, neurologist, cardiologist, and
in this case you said underlying.
Yes, sarcoidosis,
Okay.
sarcoidosis,
Okay.
endocrinologist.
Okay.
Okay. And treatment of the cause. If sarcoidosis, I will give the patient IV, vigorous IV fluid to treat of hypercalcemia, and then I will enter with high dose. First, I start with high dose of steroid to control the disease, and then taper down steroid and give after that steroid sparing. Um, and also control, yes, and control of hypertension and the risk factor, control of hypertension and control of heart rate by beta blocker.
Okay, what else?
Um,
Very important in the management.
in sarcoidosis or in cardiogenic?
No, in the presenting, the clear presenting.
Dizziness,
No,
I
this
was saying,
patient had palpitations.
yes, I will do cardiology consultation and control of rate and rhythm control of
Okay,
atrial
okay,
fibrillation, beta blocker.
okay. Okay. Um, I don't, yeah, that's good. Okay.
Okay, time is up. You can comment now based on the skills in the chat box.
In the chat box. Okay.
Yeah, verbally comment on the performance based on this every skill, started by the physical examination. Dr. Abdullah,
Yeah, I'm checking.
you are writing?
No, I'm thinking. I'm thinking.
Okay, thinking. Okay.
You are thinking about the case, Dr. Abdullah?
No, mashallah. يعني. So you can say you did very well in the. So, okay.
What is the rash in this rash, Dr. Abdullah?
Erythema nodosa.
Yes,
So
so the case
differential. Yeah.
you know, sarcoidosis with dizziness is first time I.
It's like. It's
New
so you did well in the differential diagnosis. Yeah, like yeah, I like it's I brought a case of like it's not common, but the idea is just the judgment to like you will clearly see there is underlying cause for the pre-syncope, so and the arrhythmia, so something
You mean that
so
hypercalcemia cause arrhythmia?
no, more like could be just infiltrative cardiomyopathy. Could be hypercalcemia. That's good judgment from you. Could be other causes, but it's more likely of the underlying or undiagnosed autoimmune condition. You said clearly the good diagnosis sarcoidosis. The other differential put in mind, yeah, you said all the cardiomyopathy. So let me so you identifying the findings, you I can say four for communication, four clinical judgment, four very good actually, differential diagnosis. You should put given the sudden death here is very important. Well, sorry for the judgment. I don't know if the driving here is very important. You should ask. So driving, will the welfare affected or the judgment? I don't know.
Yeah, welfare.
Okay. So the judgment, the differential diagnosis, all good. Sudden death, you didn't. Well, you put good list of differential diagnosis. I wouldn't minus. So it's four. Concerns. Yeah, you asked. Yeah, there was no much concerns actually. I didn't put concerns, so I will keep it for just the welfare here. And also you didn't put in the differential diagnosis, but it's not something to minus. The like other causes of such as lymphoma, because there is lymphadenopathy, night sweats, constitutional symptoms, and also other causes of sudden death. So hereditary genetic causes or hereditary causes causing arrhythmia and sudden death.
Long QT, HOCM.
And you focused you took time in focusing on the neurology initially, despite it's very clearly something cardiac.
Yes.
That took your focus. Yeah, but you're doing great. It's clear. Let me think. What should I? So management here focusing on the main issues, not to miss the anticoagulation, to discuss with the cardiology team about cardiology team this decision of the starting anticoagulation and control of this atrial fibrillation and the future plan, if there is any possibility of even you should consider pacemaker, maybe if considered in this case, depending on the findings. Control of there's nothing. I don't know. There's no other comment from my side.
Thank you, Dr. Abdallah.
Thank you.
Okay, thank you, Dr. Abdullah. But I want to know clearly the three differential diagnoses for this case.
Okay. So in this case, it's so the diagnosis is arrhythmia. There is a new atrial fibrillation with there is pre-syncopes and heart failure symptoms. So cardiomyopathy, underlying cardiomyopathy caused by underlying infiltrative cardiomyopathy. The differential diagnosis will be of cardiomyopathy, other autoimmune diseases, inherited and infiltrative disorders. There is the because hereditary, because she has a family history, and also I think it's not clearly. So this is the autoimmune. I said so. It's cardiomyopathy differential diagnosis. In this case, based on this patient, you will find either hereditary cardiomyopathy, autoimmune disease related, and because there is possibility of lymphoma putting in mind, and infiltrative cardiomyopathy.
Yeah, how
It's
the
something.
lymphoma? How the lymphoma can cause dizziness or syncope?
Maybe meds to the brain or like arrhythmia due to hypercalcemia. I don't know.
Okay, actually, I thought about
Vasovagal.
neurosarcoidosis. If the case is sarcoidosis, neurosarcoidosis can cause panhypopituitarism. Sorry, Addisonian. Yeah.
But it's very obvious. There is no orthostatic symptoms.
Yeah, what we can say here clearly is a cardiac cause. So this is what you can conclude from this patient or scenario. So it's a case of cardiac syncope. Why? Because there is palpitation, there is also some heart failure signs and symptoms, and some chest pain, right? Otherwise,
not chest pain, but it's palpitations and yeah. And the patient is a smoker. You didn't ask about the smoking, but like I put you too many things distracting, so you forgot. And it's not a big. Yeah.
I was supposed to ask the smoking and alcohol during examination, but the examination is.
Yeah, I will tell you, Dr. Mahmoud, what was the defect exactly. Whenever you take the history for syncope, try to finish the analysis of the syncope within 3 minutes.
Yes.
Before, during, and after. Actually, it wastes like 4 or 5 minutes still asking about the syncope. Yeah, you roll
Mm-mm.
out most of the questions and most of the causes, like cardiac, like neurological, but it was with the clue of cardiac manifestation. I think you can hurry up going to the next system or systemic review question, then the social, then family, occupational. I think also the occupational, you didn't ask about the job, right?
No, no,
No, he
ask
asked, he
Dr.
asked, he
Bassem.
asked.
Okay, good, good. But I believe it's good performance in complex case like this. You did good. The case is difficult. Even me, I couldn't correlate the sarcoidosis to the syncope. But as Dr. Abdullah said, it could be related to the infiltrative cardiomyopathy.
It is
So
because commonest arrhythmia in the sarcoidosis. Well, it's not the sarcoidosis itself. It's the to know the. You did very good in picking the sarcoidosis, but it's you can say autoimmune or like headlines, big headlines. Like
yeah,
you're
yeah,
not histopathologist to
yeah. I agree with this. I heard about one candidate. He had a case of fall, as I said. Maybe I said it before, and they brought the case as recurrent fall. And even the feedback, they didn't give a diagnosis. They wrote in the diagnosis recurrent fall. So what they wanted from the candidate to enumerate the most common causes, to ask about the medication, the complication of diabetes. Patient was diabetic, not in like our case today, but sometime they brought a case for differential, and they need from you to rule out the important causes. Okay, young patient, don't forget to mention epilepsy, but you ask about the epilepsy cause as neurological question. Did you buy it? Did you lose the control over the water work or the back passage, which is good questions. Also, shaking in the hands. Anyway, the analysis of the syncope always go with this way: before, during, and after. And you can conclude a lot of finding during taking this analysis or analyzing the complaint like this. After that, the systemic review will give you some clues, like chest pain, if you couldn't ask earlier, and you might have also dizziness, sorry, polydipsia, like in this scenario. There is possibility to have hypercalcemia, which is related to the sarcoidosis, and the patient will be feeling thirsty, passing a lot of water work. It will be in the systemic review. Other than that, the skin rash or musculoskeletal system, the joint pain also you can get it from the systemic review. Whenever you will go, the systemic review will be important. It can give you a clue about what's going with you in this case. Okay, but I believe Dr. Mahmoud did it perfect. As difficult as I said, complex case. I didn't practice it before, really, Dr. Abdullah. Like AF because of sarcoidosis or restrictive cardiomyopathy because of sarcoidosis. Anyway, it's as you said, it's a case of differential. So you have to conclude this is a case of syncope as a cardiac one with a family history or strong family history of cardiac death. So I can put the HOCM one of our differential, and I would like to do echo ECG to rule out HOCM.
And
Yes.
I'm not sure. Sorry, answering your question. I'm not sure
Yeah.
if lymphoma how is it related here. Actually, answering your question, because there is lymphadenopathy, night sweats, just because it's serious and patient middle age. But that's I think that's the. But in pre-syncope, I'm not sure.
I think lymphoma only can cause it if you have, for example, compression in the chest, major result. But otherwise, I couldn't correlate it with the syncope unless it's brain infiltration. Also could be there. Okay.
Mhm.
Otherwise, it's analysis and case for differential, and Dr. Mahmoud did it well. Anyone
Yeah.
want to comment or has a question? Both of you, Dr. Abdullah and Dr. Mahmoud first.
Thank you, Dr. Abdullah. Thank you, Dr. Bassem. No, no, doctor.
But
But
but Dr.
I
Basim,
feel.
can I, sorry. Yeah, it's okay, Dr. Basim. But if you like this, if the diagnosis is uncertain, so the explanation of the disease for the patient it should be like this uncertain, right? This is a syncope, we are not sure about diagnosis, we need to admit you, for example, under the specialty of something like that. Am I right?
Yeah,
Because he
perfect. Because you
explained,
don't have,
because he
yeah,
explained the sarcoidosis. Actually, sarcoidosis itself, it will not cause like this unless there is complications.
yes,
And
exactly. What,
sarcoidosis
yeah,
itself, it will
yeah.
not
As
cause
Dr.
like
Mahmoud
this.
mentioned, unless there is a hypercalcemia, severe hypercalcemia that can cause long QT and it lead to
Or
arrhythmia. Yeah,
cardiomyopathy, restricted
exactly. Yes,
cardiomyopathy.
yes,
Yeah, يعني to me this is a main dizziness mainly due to cardiac causes. Well, I
yeah,
don't know what is the causes, arrhythmias,
yeah.
cardiomyopathies, whatever the cause. But I mean, if I'm not certain, if the patient asks me about the concern, what I have, I think in this
This is
case I
what I
will say.
usually say. Yes.
Yeah, I will not say this is a, and I will say, for example, till now I'm not certain. We have possible causes. We need to admit you, for example, under the specialty of this to see. We need to run some blood test or imaging to yani, to see what is going behind that, and then we will treat you according to that. I think this is regarding the
Yeah,
concern
perfect
actually.
answer for the concern if you are not sure about diagnosis. And
Yeah,
then you can go to the examiner and he will try to take you to the discussion about this topic. But for the patient himself, you cannot give him, if you don't have a clear diagnosis and you cannot explain, you can say like this. But by the way, if you mention sarcoidosis because you have solid a rash, for example, or solid evidence that he has a rash, which is erythema nodosum, and you are sure this is sarcoidosis, tell him that you have sarcoidosis, but I don't know what exactly you have to explain your symptoms. However, we will do the blood test as you said. So
yeah,
don't
but
say,
because the first cause, because if the patient, I check the pulse, for example, irregular, that means the patient has
so
a
you
risk
can tell
with for,
him this is
yeah,
AF, the
yeah,
pulse
I can check,
itself, yeah, the irregularity of the
yeah,
pulse could be the reason.
yeah.
So
But regarding his mm,
whatever you have as a solid, so you can tell to the patient that you have this and it could be the reason. Otherwise, I will admit to know exactly what you have in this way.
yeah. But
Yeah,
I
what you
think
want to
in
say?
all he did great. Communication, he's confident and he's fluent. Although he miss, for example, the drugs history, the social, the driving.
No.
But
He asked the drug many times, over counter and medication lists. But he didn't
because
ask
when,
about illicit drug or party drug.
but yeah, yeah.
Yeah, yeah, it's important to ask. Yes, you're right. Yeah,
Dr.
thanks.
Hassan,
Yeah,
it's
yeah.
just regarding the sarcoidosis. I think that if the patient is polyuric and thirst, then dehydration can contribute to the dizziness. This is the main thing that we can start with. But yes, as the all of you you've summarized the relation of hypercalcemia and sarcoidosis with can cause cardiomyopathy. This is would be toward the end of the discussion with the examiner. But I think the clear if this case has been calibrated well and they want to add some cause behind the polyuria in the shadow of dizziness, then it's to prompt you to think of dehydration if the patient is dehydrated because of polyuria. Polyuria for whatever cause. It could be hidden diabetes, it could be hidden sarcoidosis, it could be hidden whatever hypercalcemia cause. This is what is in my mind. But the
Yes.
patient blood pressure is, I think it was elevated, isn't it?
Yes.
Yes, okay. So I'm not quite sure how the sarcoidosis would be contributing. Usually,
Yeah, perfect thinking to think about it as a polyuria. But let me confirm that if the patient is not passing, is compensating his polyuria, he might be okay. No dehydration, I mean. So it's an important question also to ask about the compensation, right? If he's
yeah.
compensating well, but
But
it's
in
good
this lengthy
explanation.
scenario,
Yes.
you could justify your reasoning to the examiner because if in this kind of scenario there was too many things to ask question about. So I think the main issue in this case is dizziness. We should stick with dizziness. There are some certain things that Dr. Mahmoud was able to identify as sarcoidosis. Yes, but usually they like to keep. If this case has came before, I'm not quite sure.
No, I didn't. I don't know.
Or it's been used in one of the courses. So it is. I think it's there to test if you are in kept in focus of the main problem. This is also another thing that they would like
Yeah,
to test.
focus and fast. Yes, exactly.
Yeah.
Yes, you're right, Dr. Amar. Really, it's a good comment that you try to correlate it to the polyuria. However, the patient will have dizziness from from sitting position, right? And he will tell you that he has polyuria. And when you ask about the compensation, he will say, "Yes, I'm not drinking too much." Yes, it could be as one of the differential and one of the rationale that the patient is having the dizziness or syncope. Apart from this, the arrhythmia itself can cause it, and the restrictive cardiomyopathy also can cause it. So it's clearly cardiac, and the other thing could be the dehydration due to the polyuria. Okay. Anyone has another opinion? Okay, I will prepare Dr. Abdullah, your scenario 65 years, Mr. Ahmed,
Yes.
with confusion. Speak with his son, Mr. Sami. Now the time to read the comment quickly. I have a lot of comments.
Confusion day, Dr. Bess.
It's not like dizziness.
Yes.
Okay, I will not talk about it. Let's let him
Okay.
think about, but it's not straightforward like dizziness. Okay, let's go to the comment. First comment, Dr. Samira. It's erythema nodosum dash sarcoidosis. Okay, ECG and echo. Yes, of course. Whenever you have cardiac, you have to mention them, Dr. Mahmoud.
I mentioned it already. ECG, echo, X-ray, Holter.
Yeah, perfect, perfect. Okay, Dr. Omar, present with dizziness, positive finding, regular rhythm. She described polyuria, which may represent high calcium in a bigger picture of sarcoidosis, which may contribute to her dizziness. Perfect. Differential dizziness, cardiac arrhythmia, high likely inner ear problem. So whenever you ask, you have to ask to rule out the spinning or the
Spinning.
things spinning around, but it will not be the case like our case today. Less likely neurological reason, less likely vasovagal endocrinology like Addison, but the patient exhibiting signs suggestive of sarcoidosis. Perfect, Dr. Omar. Dr. Tahani Hokam, due to strong family history. You have to put it in your differential. By the way, you have to say, I would like to rule it out. Why? Because the patient is young and he has strong family history of sudden cardiac death. And you have also to offer the screening and genetic counseling team. Dr. Alicia, Alishba. The tuberculosis lymphoma, again, I cannot have explanation if the lymphoma is there. So we have another differential now, which is polyuria. I don't think lymphoma can give explanation unless it's spreading or it has brain mets. Cardiac syncope, yes, Dr. Tahani, it was straightforward for that. Dr. Tahani, Alexandria Center, patient with all present with recurrent fall, DM, diabetic hypothyroidism, have all cardiac medication. Different include autonomic neuropathy, posture hypotension, vasovagal. Perfect. Whenever you have all of them negative, you can say this is vasovagal attack. The also medication. Don't forget anyone has a medication more than five. So you can say polypharmacy, particularly if he has vasodilator, if he has diuretics, you can put it as a differential. Dr. Ahad, I will put the differential here as follow. Heart failure related infiltrative cardiomyopathy, anemia related inherited cardiac disease, lymphoma related dizziness could be related to the underlying anemia of chronic disease. Okay, could be another indirect way. Lymph node biopsy for sarcoidosis. Dr. Ala, yeah, by doing the bronchoscopy, yes. If you want to confirm the sarcoidosis, you have a lot of investigation and imaging you have to do. I want to comment for Dr. Ala, Dr. Ahad, sorry. If you want to mention, you have to mention as well the arrhythmia. Okay, whenever you have palpitation, the arrhythmia itself can be a reason of syncope. Okay, So you can put it even before the heart failure because it's already there. Patient is having a regular pulse, and he told you that he feel awareness of his heartbeat, and the AF itself, it can cause the syncope. So I think this is the most strong differential, or the first or the top differential here in our case today. Whenever you're ready, Dr. Abdullah, we can start.
Yes, let's start. Yeah.
Yeah, okay, here you go.
Hello,
Hello, doctor.
I'm Dr. Abdullah Al-Malla. I'm one of the doctors. Am I speaking with Mr. Sami, son of Mr. Ahmed,
Yes,
and he
doctor.
is 65 years?
I am Sami, doctor. Yes.
Um, I'm sorry for your father. I'm here to ask you questions about his condition and examine him and address your concerns about him.
Yes, doctor, please. Thank you very much.
Could you tell me what brought your father to the hospital?
Yes, doctor. I live away, far away from my father. When I visit him since 2 days, I seems to be drowsy, dizzy. He doesn't know me. So I came to the hospital to know what is the cause of this confusion.
Okay.
Mhm.
And you said this is 2 days. Just I want to start. Is before 2 days he was totally fine to you?
I don't know, doctor. I live far away from my father. Just
Okay.
I came to him since 2 days,
Okay.
and found him like that.
Okay. And so have you been told that he has any injury or fall?
No, I don't think so, doctor.
Okay. And have you noticed that he is uh, what was he doing the last time that you figured out that he's dizzy?
I don't know, doctor. He is not
Okay.
dizzy. He confused. He doesn't
Okay.
know. He doesn't know me. When I visit him
Okay.
since 2 days, I came to the
Mm,
to home.
mm.
I found him confused.
Okay. I'm sorry for that. And did you check his sugar? Was his sugar low or high? No.
I didn't check, doctor.
Okay. And what? Okay. And what was he any sweating? Does he have any abnormal sweating or clamminess? Abnormal
No,
skin color?
no, doctor. I don't think so.
Okay. Did he have this condition before? Similarly?
No, no.
Okay.
This is the first
And
time.
did he get any in like similar? Did he get any previous history of infections anywhere?
Previously, no, no, doctor.
Okay. He got any history of hospitalization to the hospital?
No, never, doctor. Never.
Okay. And any history of surgeries?
No.
Okay. Did he have any known medical conditions such as high blood sugar, diabetes, high blood sugar
Yes,
or
doctor.
high blood pressure?
Yes, doctor. He has high blood sugar.
Okay.
Mhm.
And how is the follow-up with the doctor, his doctor, about this high blood sugar?
I think, doctor, he visit always the clinic, but I don't. I'm not sure because I'm
Oh,
away from my father.
okay. And so have you been noticed that he's having um, any abnormal frequent urine water work?
Yes, doctor, you are right. Yes,
Okay.
since I came to the home. Yes, I think it is increased amount of water.
Okay. And was there any um, so did he have any abnormal for how long he has this frequent urine water?
Since 2 days.
2 days. Okay.
Mm.
Was there any abnormal pain with that, with the water work?
No, doctor, I don't think so.
Okay. And any redness or blood?
In the water work, no,
Yeah.
no,
Okay. Have you got any throwing up or or any feeling about to throw up, sickness feeling?
No, doctor, I don't think so.
Okay. Was he able to eat? What was it last time he had a meal?
No,
Or
doctor.
was his
No, I
eating
don't.
affected or drink? Okay. Did he have any tummy pain?
Tummy pain? No, doctor.
Okay. And did he have any headache?
Headache? No.
Okay. And did he have any weakness in the hands or legs?
He can't move, doctor, because
Okay.
his confusion.
For how?
So,
Okay. Is he usually able to move?
yes, doctor, yes.
Okay.
I saw my father since 2 months. He was fit.
Okay. And is this weakness any? Is there any difficulty in? Did you feel his face? Is his mouth is like to one side
I
or
don't
the
think.
face? Okay.
No,
And
doctor.
okay. And did you feel that he's unable to hold objects in his hand, for example?
I didn't try, doctor.
Okay.
Because
Oh, because of the confusion. Okay.
confusion,
Did
yes.
he? Yeah. Did he have any high temperature or
Um,
feeling warm or high
mm,
temperature?
no, doctor. No.
Okay. And did you feel that he has any abnormal back passage, hard back passage or loose back passage?
Yes, doctor. I think so. Yes, I think
Is
he
it
has
hard or loose?
hard. Yes, hard, doctor.
It's hard. Okay.
Yes.
Okay. Is it something? Okay, it's hard. Any blood in the back passage?
No.
Okay, and this hard back passage for how long it's happening?
Since 2 days.
2 days. Okay.
Mm.
And did he have any abnormal? Did you feel his walking is abnormal?
He can't walk, doctor. He
He
confused.
can't walk. Okay, he's confused. Okay. Did he have any feeling of? Did he complain of his any numbness or tingling in hands or feet?
I don't think so, doctor. I don't
Okay.
think.
Did you feel? Was this starting? So before 2 days, you noticed that you didn't know before, but this is started so quick, or was it something gradually?
I think it is the same, doctor.
Okay.
Mhm.
Okay. And anything make it better? Did you notice like anything make it better?
Yes, doctor. I try to speak with him, talk with him. I try to give him
Okay.
some painkiller,
Okay.
but
Okay.
not improved.
Okay. Is his swallow affected? Did he choke or have any problem with the swallowing?
I don't know, doctor. He can't
Okay.
can't eat.
Okay. And did he have any problem with any coughing or problem in the chest or shortness of breath? I'm
Cough?
sorry,
No.
coughing first.
Cough? No, no, doctor.
Okay. Any shortness of breath?
Short of breath? No, doctor.
Okay. 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 I'm sorry for the question, but does he smoke, your father?
Yes, doctor. He smoke.
Okay. For how many?
Sorry, Abdullah.
Okay, I'll give him some time to do.
From Dr. Abdullah. Okay.
Yeah, I will pause the time.
Mm.
Yeah.
Yes, Dr. Abdullah.
Yeah. Hello, guys.
Yes, Dr. Abdullah, I'm with you. No cough.
Yeah. Okay. So how was there any smoking? How much cigarettes and for how long?
Yes, I think 10 cigarettes for 20 years.
Okay. Okay. And does he drink alcohol?
No.
Okay. Well, I'm sorry. In this situation, once your father is able to, I'm sorry, we will figure out the cause of his underlying the confusion. But smoking is not advisable in his condition, and we will do our best to help.
Okay, doctor.
Okay. Okay.
I will tell him that.
Okay. Any family history of conditions of family history of high blood sugar, diabetes, high blood sugar conditions?
Yes, doctor. I think my grandfather died due to heart attack.
Okay. And any family history of cancer?
Cancer, no.
Okay. Does your father have any condition of heart disease? Any heart attacks?
No, doctor.
Any attacks in the brain
No.
causing weakness, or they call it stroke? Okay.
No.
Okay. And okay, I will start. Does your father take medications?
Yes, doctor. He is on insulin, 10 units per
Okay.
day. Mhm.
Okay. And did he have any previous history of low sugar?
Low sugar? No, never, doctor.
Okay, 10 units per day. Okay, and was there any other medications that he take?
No, doctor.
Any over the counter that you know of?
No.
Okay, and was there any recent change in the dose of insulin?
No.
Okay.
Actually, doctor, I don't know because I live far away. Yes.
Okay. And who does live with your father
He live
at
alone.
home? He live
Doctor.
alone. Okay. And was your father married? I'm sorry for the question, but how is the health of your mother?
Sorry, Dr. Abdullah, but Dr. Basim, the time is paused. Okay.
Dr. Bassem? Yeah.
Okay.
How's the condition? How's the health? Since when he's living alone?
Since 5 years.
5 years. Okay. And what happened, if I may ask?
Sorry, ask about?
So,
ask about what?
So, anybody supporting him at home? Any carers at home?
No, doctor. He has many friends. They visit him every day.
Okay. 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 So I will start examining. I will examine the vital signs, updated vital signs, the blood sugar urgently.
Yes, blood sugar 300.
Okay. And I will check the abbreviated mental. Well, I'll start with the 480 score for delirium.
Yes,
and also abbreviated mental status abbreviated mental status score. And so, was there any? I will check with I'll start looking in the patient's hands, checking the fast face for mouth deviation, and I will check the inattention. And hand grip, pronator drift.
Okay, pronator drift negative. Okay. The pulse 90, and the blood pressure.
Is the pulse regular?
Regular, doctor, yes.
Okay. The blood pressure?
120 over 80.
And I will check the pulse. Was there any chest pain?
Chest pain, no, doctor.
Ideally, I would take history. I would check the disorientation. If the 480 score is high, well, this station is from the sun, but ideally, I would take collateral history from somebody who knows. Okay.
What is the collateral? Sorry again, Dr. Abdullah. What do you want exactly in the patient?
Okay. So in the patient, if the okay. Well, so is there any features of injury? Is the patient in pain or not?
No, doctor, but the patient seems to be drowsy.
Drowsy, okay. And is there any yellow discoloration?
No, the eye has some pallor.
And some pallor, okay. Any bleeding anywhere? I will ask son, and I will Yes.
Like
Any
what,
black stool?
No.
He doesn't know. Okay. I will ideally check rectal examination once the patient is less confused, and I will.
No need,
Okay,
doctor.
no need.
Okay.
Okay. I will check the mouth, and I will check
Mouse,
lymph nodes in the neck.
mouse normal, lymph node check. No, normal,
Okay.
normal.
I will
Okay.
ask the patient to give me to walk a little stance, and I will check his
He
gait.
he can't, doctor.
He can't. Okay. Ideally, I check the power and
Okay, very good.
reflexes in the upper limb and the lower limbs.
Okay, the tone is normal. Power is normal. Coordination can't be assessed due to confusion.
Reflexes, power, yeah.
Reflex normal.
And power is normal. Okay.
Yes,
And
doctor.
is it okay? And
2
okay.
minutes
And
left.
is the patient okay? Ideally, this patient should be catheterized urine, and I'll check any tummy pain, and I will listen to the any crackles in the bases.
No, doctor. No crackles.
Okay. Any tummy? Is it the top abdomen soft?
Yes, doctor.
Okay. And lower limb edema?
Lower limb edema? No.
Okay. Okay. What is your concern, Mr. Ahmad?
Yes, doctor.
Sorry, Mr. Sami.
Mr. Sam. Okay, is it heart attack?
Well, that's something that we need to well, it's something that's in the possibilities. We need to rule it out by doing heart tracing.
Okay. So
Any
it is high possibility, doctor, to appear heart attack, like my grandfather.
given that there is no chest pain, but in this situation, the chest pain can be absent. So we need to rule it out by doing blood test and heart tracing.
Okay. So what do you think about the cause, doctor?
The cause is there is the problem is the control. The blood sugar is very high, and the confusion more likely due to this the underlying sugar condition, the diabetes or underlying sugar condition. But we need to rule out other. We need to. So this is the first thing we need to control, and it's more likely the condition causing the disorientation, and also we need to manage as emergency to control this high blood sugar, and we need to keep him in the hospital, and we need to rule out other causes such as abnormal blood salt concentration and heart attack, and infections, underlying infections. Any other condition? Any other question?
No, doctor, thank you.
Okay, examiner questions.
Okay, doctor, tell me your positive signs in this patient. Positive finding in this patient.
This I took history from about Mr. Ahmed from Mr. Sami, his son, and his father presented with the from the for this is from the collateral history that perceived from the son's 2 days history of disorientation and causing there's features of polyuria, and from the underlying diabetes. The patient takes insulin 10 units with no change in the dose. That's recently before the confusion. Examination is unremarked. It's difficult to examine the full neurological system, although there is no focal neurological deficit on examination, and the patient has high blood sugar. There's features of high blood sugar of 300 milligram per deciliter. I could not appreciate any other underlying likelihood of the disorientation.
So, doctor, what is your differential diagnosis? And what is your differential diagnosis in this patient?
My differential diagnosis is that first hyperglycemia emergencies such as diabetic ketoacidosis, more likely predisposed by infection or ischemic heart disease or poorly controlled diabetes. Although I'll need to the full history or accurate history is difficult to ascertain because of the disorientation. And there are social conditions in the patient. The patient lives alone and did need to, so there is a difficulty to get a proper underlying condition or cause of the triggering this poorly controlled diabetes or high DM at the moment. Other differential diagnosis is that for the confusion could be underlying neurological condition. So we need to do urgent. So underlying neurological condition such as a stroke, other space occupying lesion, or others intracerebral hemorrhage, and this abnormal electrolyte, such as because the patient has a constipation, it could be hypernatremia associated or hypercalcemia associated.
Okay, doctor. So what if I told you that CT was normal and no ketone body in the urine? So what is your differential diagnosis?
So in
And
this gentleman,
and the echo and the ECG was normal also.
Okay, so I would consider I would consider that delirium from possible underlying sepsis as one of the causes.
Patient also has no fever.
Okay.
Okay, doctor. Okay, Dr. Abdullah, thank you.
Normal pressure, hydrocephalus. Well, but I could not appreciate the patient gaits because of difficult.
Okay, Dr. Abdullah. So what will you do to this patient?
So I need to urgently assess the. I need to keep a patient under the medical ward, assess keep the patient one-to-one observation by carer for safety, not to fall, and a multidisciplinary team. Oh, you mean investigation? Sorry.
Okay, investigation.
Okay. Basic blood tests, full blood count, looking for any anemia and infection markers, white blood cells, C-reactive protein, and liver function tests, kidney function tests to rule out uremia, and electrolytes, full electrolytes, serum calcium, potassium, sodium, phosphorus, magnesium. I will need to a blood gas test to look for the anion gap, if there's any acidosis. And also I will need to chest x-ray, urine culture, blood culture. I will need to do CT brain. You said CT brain was done, and I will need to look for a I will need to get frequent blood sugar monitoring, and given this gentleman is 65-year-old, I wouldn't suspect drug toxicity, but that would be put in the consideration. So urine toxicology, yeah.
Okay, doctor. Okay, doctor. So, okay, what about polyuria and constipation? So, what brought to you?
So,
And if I tell you that the patient has back pain
okay.
and pallor, so what condition?
So in this condition, yeah, I would consider about multiple myeloma, about the
Yes, doctor. And what is the cause of confusion?
that's caused by multiple possibilities. In this case, hypercalcemia,
Yes.
can be uremia, can be paraproteinemia.
Yes, doctor. Yes, Dr. Abdullah. So that is the case.
Okay. Yeah.
Okay, thanks, Dr. Abdullah. But I don't know why your information was good, but you are hesitating. I don't know why. I think
because I missed
you are hurry to know the diagnosis.
I missed the case.
No, it is not missed. You find it is hypercalcemia. This case came many times in Egypt. This is a case of confusion since 2 days, and the surrogate is the same. He tell you that I live away from my father, and I came since 2 days. The same. So in first we have to exclude vascular cause, like he have any weakness, any numbness, any stiffness. She will tell you I don't know. Then you will check if there is any stiffness to check about the infection from our side, any neck stiffness, any cough, any racing heart, and systematic, any cough, blood difficult to breathing, and then the urinary, any change in the amount, frequency. Yes, she will tell you that increase the amount. So we have two possibilities, either DK or hyperosmolar non-ketotic, or maybe hypercalcemia. So then we ask about any tummy pain, any constipation. So she had constipation. So then your mind will be directed to any cancer, any past history of cancer, any back pain. It would be multiple myeloma. You will tell this doctor, I think he had back pain and he can't stay in the bed due to back pain. And also, you remember me about party drugs. You also should ask about any party drugs, any illicit drugs. Yes, and also ask about put in your mind any metabolic cause. And also you asked about trauma. It is very good thing. And also, yes, during examination, you should exclude any examine neuro, cardio. So you should examine neuro, pronator drift if you don't have time, and also one tone, one power, and one reflex. And also you should do Babinski sign. If it is upgoing blunter, so it will be neuro. And you should also examine the carotid for any bruit. You should examine for the heart, for any murmur in the heart. You should examine for the chest, for any crackles, anything like that. And also you should assess, first you assess what mini mental and like that. Patient not have dementia, patient has confusion. So you should, yes, you should examine conscious level of the patient, because it came before in Egypt also, and the examiner asked the doctor what is the Glasgow scale of the patient. So you have to assess the Glasgow score, not assess the mini mental score. And also you should ask about the memory. I will tell you the target. I will tell you I don't know, but you should ask about what's the memory, any change in the memory, any change in the behavior. Did he see anything like dementia? Did he see anything not present? Did he talk anything? I will tell you no, I don't know, but you should ask.
That's a good question. Hallucination. Yeah.
Yes. I will tell you no. The surrogate will tell you no, but you should ask. The differential diagnosis for the patient, to the surrogate, yes, I have to do. We have to admit the patient. Even hypercalcemia alone, it is a need for admission. So you tell the examiner and the patient, we will admit in the ward. Patient hypercalcemia. I think it is just to say admission, because this patient may need admission in ICU.
ICU, yeah.
Yes, if the GCS blows 8, he will admission in ICU, intubated.
Yes.
So admission, first admission. Second, we have to exclude central cause, so we have to do CT brain and ECG and echo, and then treatment of the cause, hypercalcemia, IV fluids, investigation for the cause, like protein electrophoresis, and also MRI brain, and we need bone biopsy, and then treatment. I will admission and IV fluid, and treatment of the cause of multiple myeloma, apart from non-pharmacological and multidisciplinary team. I will give him steroid, and according to if the patient fit for chemotherapy or we need lung transplant. The important point, Dr. Abdullah, you take along with the examiner. The examiner just 5 minutes. He need 1, 2, 3. He need admission, IV fluid, and treatment of the cause of multiple myeloma, protein steroid or chemotherapy, and then bone marrow transplant. If you don't tell one of them, you will get unsatisfactory. So you have only 5 minutes with the examiner. You should examiner must be satisfied to give you satisfactory. So you had to be fast with the examiner. Differential diagnosis 1, 2, 3, and the clinical judgment, investigation, treatment.
Okay.
You should tell all of this.
Okay.
Because even if you know the case and tell the differential diagnosis for the case, and even tell the examiner the investigation, if you don't tell the treatment and the time finish, he will give you borderline, because you didn't tell the treatment. That is your time. So the time management in the 15 minutes, you should have time management, and time management in with the examiner. That is the case. Yes, and the second, the first diagnosis. First, we have to exclude multiple myeloma, more likely multiple myeloma. And if the examiner told you what is you have any other diagnosis, I think yes, diabetic ketoacidosis, but the patient will be acidotic, will acetone smell like that. No, there is another differential diagnosis. The examiner like hyperosmolar non-ketotic. So second differential diagnosis may be hyperosmolar non-ketotic, and also I should do ABG to see if there is any acidosis or any acetone in the urine. So it would be DKA. Also, the treatment is the same. It will be IV fluid. Thanks, Dr. Abdullah.
Thank you. Very good case. Thank you so much, Yusuf.
Thank you, Dr. Abdullah. It is very common case in Egypt.
Okay.
Thank you, Dr. Mahmoud. You want to scale him on the scale mark?
Yes.
From the physical examination, did he cover all the physical examination?
No, Dr. Basim, I think no. He didn't.
Okay,
he examined the neuro. Yes, he examined the neuro. Dr. Abdullah examined the neuro. Not like if the patient
not in detailed. Okay.
Yes, not in detail. And also he examined the heart. So borderline, yes.
Identify. Could he identify the finding in this patient?
Yes, identify physical finding satisfactory, Dr. Basim.
Okay. And the history?
Yes, taking history, he missed the bone back pain, and also he didn't ask about any diabetes complication.
Yeah,
and he didn't ask anything about diabetes, because the
hypoglycemia. I will comment on this. Yes, but
yes,
no, I asked about the diabetic complication.
No, Dr. No.
No. You miss even the hypoglycemia.
At the end, this Dr. Basim. At the end, Dr. Abdullah tell me any stroke, any heart attack, but not organized. The examiner will be very angry. really,
Okay.
because
Okay.
I did the same with my exam previously, and he did
Yes,
very
Oh my
angry.
God.
clinical judgment. Did he?
Okay.
Clinical judgment borderline, Dr. Basim, but he forget MRI, forget
Okay.
urine acetone in the urine, EBG.
Differential.
Definition unsatisfactory.
Unsatisfactory.
Sorry, Dr.
Okay.
Abdullah.
Yes,
No
yes,
worries.
no, you are right. Unsatisfactory, yeah. I'm saying.
Yes. Did he answer all concerns?
Yes, he tell me admission, and he need me might be due to blood sugar, but he forget to tell the patient that might be cancer, so it is borderline.
Borderline, yes. And welfare, borderline, because also it's something he should put in his mind that it's a
Yes.
cancer. So the admission here is crucial, important. So we can get um, 2, 1, 2, 3, 4, 5, 10, 14 out of 28. Okay. You will see the skill mark on the Facebook, Dr. Abdullah, if you want to see exactly
Okay.
what the satisfactory, what's the
Great.
borderline, what's unsatisfactory. I will post it in the in the Facebook. Let's start the comment. I
Great.
agree with Dr. Mahmoud regarding the history itself. It was
Yes,
yes, but the good thing in
history.
this,
Yes,
it's
Dr. Basim.
faster than before. Dr. Abdullah really, he was taking the history little bit slowly, but today he was, yeah, he's hurried, but still, but better than before and faster than previous performance. So I could say it's a good step to be improving whenever he's taking history.
Yeah.
But he should do the best and approach systematic, organized questions, system by system. I think Dr. Abdullah he couldn't do this, so it again
Yes.
it's something to need to be improved.
Okay.
Yeah, the diagnosis, as Dr. Mahmoud said, you didn't cover the most important, which is multiple myeloma. Patient is anemic, having the polyuria. So you couldn't think about the. What I can say, it's linked skills means that if you couldn't say good differential, you cannot say good clinical judgment. You cannot do good examination. You cannot also give or get good mark in the concern because all of them are related to each other. It's called linked skills. So whenever he will minus you in one, he will minus you in all because it's related to
Others.
each other. Yeah.
Okay.
I think this is the most important point to mention. The hypoglycemia, never ever have patient with diabetes with confusion and you didn't ask about the hypoglycemia right now or before. You have to ask them. Okay, you have to rule
Okay.
it out and you want to check his blood sugar. The neck stiffness is very important in such age to rule out meningitis or encephalitis, any contact with sick patient. However, you
Okay.
ask about any infection, but the contact itself you have to ask. And the good thing also here you ask about, yeah, I mentioned the infection, but again, the sick patient is very important to ask. Does he have any or did he have any history of contact with sick patient? The fever, constitution symptoms, I think you ask. The fever, loss of weight, appetite, you miss them, right?
I missed. Yeah.
Yeah, it's
Constitution.
important as well because it can give you also a red
بس
flag.
كمان عندك ثلاثة الثالثة
This
مش لاقيه.
patient is having something
Yeah.
serious that should be either admitted or, sorry, I will just,
Okay.
okay, someone, no, it's okay. So you need to do admission and the patient should be followed with multidisciplinary team approach on time to rule out the most serious thing, which is meningitis, or if in our case today, supposed to be a cancer, but the cancer will be like longer history, not in 2 days, as a multiple myeloma. But the common now to have confusion, maybe something metabolic like HHS. They don't like the hyperosmolar non-ketotic, Dr. Mahmoud. It's called HHS, hyperosmolar hyperglycemic state.
Ketotic.
Okay, hyperosmolar hyperglycemic state,
Mhm.
HHS. Okay, or constipation itself.
لا ده مبلوغ.
Elderly are very sensitive to the constipation. They might have. Sorry, I will mute this. They have very sensitivity to the constipation. Whenever they have constipation, they might have confusion. Not only this, even the dehydration can cause this thing, as long
Okay.
as they are frail, living alone. Even he's saying, I'm not living with him. You don't know what about his oral intake, is he taking it well. So all of them can be a trigger or even the cause of his constipation. Okay. This is the most common and very, very important to roll out. So let's repeat the differential in order again, as the confusion: hypercalcemia, sorry, related to the multiple myeloma. The second
Yes.
will be the constipation, and the third will be
I think
yes,
hyper
hypercalcemia and constipation,
and
and
hyper
we can
hyper
say
hyper osmolar.
hyper HHS, yes, the metabolic electrolyte, and again the metabolite, which is hypercalcemia, metabolic hyper hyperglycemic state, and the hypercalcememia. Yeah, so they are the same: hypercalcemia, hyperosmolar, and constipation. Three of them. Okay, I
Yes,
think
Dr.
this is the
Bass.
most sensible differential.
Yes.
Yeah, but you have to think about meningitis or encephalitis after rolling out. The UTI itself could be there. He mentioned polyuria, right? So you can say,
Yes.
but he
Yes.
denied any urinary symptoms like micturition, permanent
Mm.
micturition. So you cannot say this is a UTI, but you can think about it. Or any infection in elderly can cause the confusion. Yes. Okay. Anyone has a comment? Dr. Abdullah and Dr. Mahmoud first.
Thanks, Dr. Basim. Thanks, Dr.
No,
Abdul.
thank you. Thank you so
Thank you.
much, Dr. Mahmoud, Dr. Basim.
Okay, let's
Very good
open the
case.
discussion. Dr. Mahjoub, you want to comment? Because he's always commenting nicely. Dr. Mahjoub, or anyone, not only Dr. Mahjoub, but
Bassem,
anyone. Doctor.
Dr. Bassem, my comment is to Dr. Abdullah. He
Mhm.
has a very good knowledge
Yeah,
but he misses the
yeah.
connecting this knowledge. This is
Yes.
what I noticed. Once he figured out that this is a case of likely multiple myeloma, he brought up the paraproteinemia, which can lead to venous thrombosis and increased risk of thromboembolic symptoms, hypercalcemia. So, but my advice, Dr. Abdullah, is to be confident. I don't know if he's
Okay.
giving the exam in the UK or overseas, but the confidence
Overseas.
is if it's an overseas, also they like the confidence. The confidence is
Yeah.
something you can train on in front of the mirror, open a camera and see what's your body posture, what's your um uh like how you look like. Because if you are looking down, if you are avoiding eye contact, if you are not
Mm.
controlling your nerves, this is a thing that would make the case lost from you because you are very stressed. And this goes only with practice, to be honest. You've
Okay.
commented on very, very good comments like one-to-one. No one will comment this, to be honest, about one-to-one care um, during admission. So you have it, you know it already. So try to um, uh, practice it with yourself
Okay.
um, in a very, um, uh, stable tone of voice. This is
Great.
my advice.
Yeah, I think the repetition as well, Dr. Omar, will help him
Mm.
because these information need to be organized and put on place. That's it. He has it, but he couldn't arrange them in good way or a proper way that it can give him or give the examiner impression this perfect, or he has good confidence to be a candidate or a candidate. So this is I think, yeah, it will be acquired from the practice. Thank you, Dr. Omar. Anything
Thank
else
you.
you want to add?
Don't give all what you have
at once. Because if you did, I tried to do the same, but I was advised not to do that. Let the examiner guide the questioning. If you are someone who, when he talks, he might miss. So this is different from person to person. So you know what I mean. So because in the real exam, the examiners would stop you. So don't panic when they stop you. They
Okay.
stop you because they have time, their own time to manage. So like for example, this is a case of XYZ, and he has big. I think this because he in the history there was XYZ, and in the finding there was XYZ, and stop. They might ask you what else you have found. So they are trying to guide you toward certain thing. I don't know.
Sorry, Dr. Omar, what is XYZ?
XYZ like 1 2
Yeah,
3 يعني.
well, ABC. Oh,
تمام
ABC.
تمام تمام.
Okay, it's not a
Yeah.
condition. XYZ.
I think
Okay.
it was a condition.
No, no, it's like, yeah.
Nice. Thank you, Dr. Muhammad.
Thank you.
Thank you, Dr. Omar. It's a nice comment and a helpful one. I think Dr. Omar will gain all these skills from practice. If he has
Yeah.
good partner as well, face to face will be more important. It can give you a lot of confidence, and the rate and the flow of question will be much faster than the online one. Okay.
Yes,
There is
I
one
think
AI tool that it is, I think, Coach Paces, which can help in practicing alone.
Well, what do you mean, Coach Pace?
It's an AI tool.
Oh, okay.
I found it recently, to be honest. It's called Coach Paces. I think it is ridiculously expensive, but if a group can do subscription,
Yes, and I practice also Dr. Omar with ChatGPT. ChatGPT, I
but he
practice,
interrupts stupidly. I tried.
but really I practice with him very well. Really,
So
especially
what's your
Yeah,
prompt?
it's a
yes,
good one.
especially communication very good.
What's your prompt? That do you have a prompt to for that GPT, or you are opening the chat GPT? That's it.
Yeah, this
Yes,
is an instruction. You can give whatever as an instruction and tell him
yes,
what you want, and he will follow.
No, if he's less interruptive with Dr. I'm sorry again, Dr.
Mahmoud.
Dr.
Mahmoud.
Mahmoud.
Dr. Mahmoud. Do you have you made like a prompt for your
Not
GPT
brand,
to?
you know, I take yeah, from camera the scenario and ask him to practice with me. So he is the patient or the surrogate, and I am the doctor.
Maybe the
Because
medical ChatGPT, right?
I don't know the normal ChatGPT, but
because I tried, to be honest. I have this.
it paid. I
I'm
paid to
subscribing. Yeah, I'm with the subscribed one, but it's stupid. My issue with it stupidly interrupts me. I don't know why it's doing that. So I like kind of um,
Okay.
fed up on
At,
him. But
at least, Dr. Omar, you can find a way. This is what I want to say. It's
yeah,
better than nothing, or better than
yes.
just listening.
yeah.
Okay. Yeah, it's you can if you can do. I can encourage some of you to do and to try it. If he likes it, or if you like it, do it daily basis or even every other day. But better than nothing, or if you don't have a partner. But the best way is to have all face-to-face partner in your country, in your hospital, whatever the position
Can
or
I
the
can
place.
I advise Dr. Omar to get a better ChatGPT response? Dr. Omar just post for him YouTube links. There is a communication stations which is on YouTube public, especially from the NHS, done by Dr. Poniker, done by many doctors. So try before you start practicing to show him good examples, and believe me, he will follow. Because ChatGPT, it depends on how you
feed
يعني
him.
how you make
I
it, you are the one who will make him
The
get
this is
used
instruction,
to the
this is
yes.
why I
response.
asked about the prompt. If
Yes, I
Dr.
agree with you.
Mahmoud
That's why
had a prompt
when I
already
saw you
made, yeah,
asking, I
yeah,
understood that you want the keywords which would
yeah,
make him help. In such scenarios where you want to practice with him, it's better to show him a full example rather than giving him a prompt. Because what will help you is to understand that there is an exam, don't interrupt, how is the concerns, 10 minutes. So he will understand all those things better from when you will post for him a YouTube video and tell him, please, I would like to practice in the similar way like this, and put for him a scenario and check how it will be. I think it will be better.
yeah.
Yani we have to let our ChatGPT understand what we want.
No, I'm good at using ChatGPT, but I was wondering what I'm doing wrong, so I'm getting this
No, I agree with you
interruption.
because sometimes it's too much helpful and you were able, like, as if you find the keywords to use it correctly.
Mhm.
And sometimes I feel it is not giving me the results I'm expecting.
Okay,
So,
let's
but
invite
this
him
thing
to
will
our
help.
meeting a
Mhm.
day. Let's invite him to our meeting a day, and we'll tell him this is what we want to do.
Do you know,
No,
even now
there is
they
a group
open.
chat. There is a group chat in the same chat. This is the upgrade.
Oh,
Um, so if you are opening like a chat practice, Dr. Hind, you can send me the link, for example, and the whatever you fed that GPT, it will be showing on your side and on ours, on anyone you've shared the link with that
Oh, I
GPT with
get
it.
you. So whatever I trained my GPT to do, you will be able to get benefit from.
Yes. So
This is
if
perfect
we can we
because
can we
Mhm.
can build some GPT to help the
Community.
group.
Yes, something like a community. Because really, I noticed that sometimes the response of ChatGPT with some of my friends is better in some aspects, and in some points, no, it's better with me. So I think it depends on how frequent and what the type of question do you ask
Yeah,
usually, so it
so
learn.
this is what I wanted to ask Dr. Mahmoud if he had already trained his GPT on to give
For
him this very
communication
good
too much, it will be
response.
very helpful.
Yes, for
خلاص
communicate,
يعني.
I tell ChatGPT told يعني explain to me كذا discuss with me this operation, you are angry, make you are want to raise a complaint like that, and
So you
he
are trying to calibrate the case with him before
yes
you are
before
practicing.
the case, yes, and even the ChatGPT close it and يعني قفل الموضوع معايا برجع اقول له no make كذا كذا كذا
yeah.
So I
XYZ
think
XYZ.
such a way will teach the engine. It will become each time better than
Yes.
يعني
Yeah.
better than the previous time. And I think, Dr. Mahmoud, you are noticing that the practice with ChatGPT with time is better, even for you, right?
Yes,
If
yes,
you
Dr.
can,
Yes, Dr.
يعني
Hind.
with
instead
time,
of
the engine is learning
Mhm.
the steps, the calibrations, the concerns.
Yes,
So if now as Dr. But is it open for free user, Dr. Omar, to open a
it's
chat discussion?
so if Dr. Mahmoud, if for example I made my own GPT for certain tasks, but if Dr. Mahmoud, instead of making this instruction to the conversation section, try to open my GPTs, if as because you've already
okay, Dr.
uh,
Omar, I will chat you. No, no,
uh,
no issue.
uh,
My chat GPT will train, really, will
yeah,
train.
I know. This is I know this is
Perfect model for training.
you've been successful to let him know what we really need. So this is a very like on it's not done on a single day, maybe on 30 days
No,
in
no,
a
no,
row.
it will never. I think he is
Yeah.
practicing, and the number of scenarios must probably you have been already in يعني practicing them too
Mhm.
much. I agree with Dr. Omar that such a training it costs money later on, Dr. Mahmoud. You shouldn't charge us for it.
No, Dr. Hind,
Uh,
But
it is for
but you know, Dr.
No,
Hind,
no,
it's better than wasting the time without practice, without
no,
having
no.
a
no, no,
I'm
partner.
it's
sure,
very good.
and being patient will give you
Yeah.
results with time.
Yes. Exactly. Yes. I hope everyone can try it, and he can train him according to your wish. Whatever you want, he will do. Try to do it better than, as I said, having no
But if you
partners.
people manage to make it a chat for each other to exchange whatever related to communication station. Engage me with it, okay?
Yes,
Because I used to
there
write
is
in a different way. I used to write the transcript by myself, especially for some scenarios, and paste the whole transcript, which took time, and try to teach him what is the optimal concerns, because يعني, I would like also to have such a opportunity for practice on any time.
Okay,
But
it's good.
I stopped doing it. Like I was too much into this for some time. Then I stopped, يعني. So if you people gonna do it, يعني, I would like really
We can make a subgroup in the community. If anyone interested, he can join.
Yeah,
and we
I'm
Then
can
interested.
open it together. Then we
yeah,
will
yeah,
benefit from whatever training we did.
yeah. I think so also.
And also one thing, Dr. Basim, if we can designing upcoming scenarios, if we did it in according to the layout on the RCP, this would be helpful because sometimes in a very lengthy scenario, like without dizziness or whatever, they will put bits and pieces for you to gather in order to organize your thoughts instead of like saying Ahmad has presented with dizziness, address his concern.
mm, like yes, like palpitation. There is also scenario in RCP about palpitation.
Yeah, like instead of giving one line, it's to
Yes,
be written in the same, and whomever is preparing a scenario, he can use the ChatGPT, the free version, to make a likelihood scenario. You can tell him, I need the candidate to identify X, Y, and Z. Because sometimes peoples have different linguistics and they might not be able to express what they want in the scenario, and therefore they might be afraid to write a lengthy scenario or a full text, or finding this difficult or time consuming. I think this would be helpful in collecting several scenarios that it's good to be used later on.
The idea, Dr. Omar,
Mm.
it end with a summary of complaint, and you won't say the vital signs. It's the same as the exam. Yeah, I believe the exam is longer, the scenarios, but the same idea. You have to know the complaint and to analyze it. What the benefit of asking to
So,
collect
for
the
example, if
data?
you usually they will try to be they will give something not to throw you for the whole differential in dizziness, for example. They will write that he has a background of XYZ, and if the patient has background of certain autoimmune diseases, for example, and they want you to think of Addison's, you get what you get, and they are
yes,
You are
awaiting your
right.
top
You are
differential to
right,
but
be like
Dr.
this.
Omar, that sometimes the scenarios, which is the real scenario, they are more easier than the scenario which we practice. But to be honest with you, this is not the practical way to practice, because it depends on the center, it depends on how the scenario was made. As if some people, if they know that this scenario has come in the exam this way, he will share it with you. He will not hide anything. For example, something related to lithium toxicity. I know one scenario given to me after an experience. A whole story was given to me by the candidate who did the case. Whenever I do that scenario, I put those extra information because خلاص,
Yes.
I have it. But let's say that I took a course. I didn't go
They
into
they
a mock.
play. Yeah, I know.
I don't have a friend, but still I want to practice. And I'm using the scenarios, the teaching scenarios of the course, which was not prepared for the purpose of the real exam. Rather, it was prepared for the purpose of teaching and make you ready for any differential. So you cannot ask this to every person practicing online. It depends on how much he was يعني how long he have
he's
an
prepared.
experience
Yeah, I know. I
with
know.
this. So you get me? Even if he asked a chat GPT, he might come up with an idea which is totally not realistic, and you will suffer
No, no,
because you
but
ask him to
what
use
I'm asking
chat
is that
GPT
no,
and he
no,
don't have any
there is three or four
background.
differentials. There is three or four differentials. For example, for common differentials for dizziness, let's say, that it will be there if you they are playing the game of substitution.
Directing you. Hmm.
Substitution. Like, for example, this diet dizziness has came because someone has dizziness secondary to his vasovagal because of polyuria. Next diet, it will be for a different reason within the list. So
Yeah.
they are
By
playing the
the way, Dr.
substitution.
Omar, most of the scenarios from candidates, they have practiced it in their exam, or they heard it from another exam from other candidates.
Mhm.
As Dr. Hind said, so it's a matter of already having this case have already practiced in an exam. You got it?
Yeah.
It might be that the person who gave me the case, he gave me the full information, so I transferred this information from my friend to you, or he might just want to help me. So he gave me one line, I practice it with him. So when I will do the same. So it depends how much information we get, either from a course or from a friend or from an experience session, someone who is telling us his experience. So how much I wrote after him. Either I wrote the vitals or I wrote the idea. It was palpitation and the case was Holcomb. So this thing, I agree with you. That's why some tutor they play on this thing that we bring real cases, which is easier than practicing the whole differential. And they work on to pushing the candidates to give the full feedback. Even they push them what was the vital, what extra past history was given in the scenario. One of them is Dr. Ahmed Aidi. He loved to give the scenario with extra information as if you are in the exam to help you
Yeah.
guided from the beginning rather than
Yeah.
يعني being lost in this big differential. So this, whatever you are mentioning, it is usually what is happening in the exam. But what we usually practice online,
Yes.
the better for teaching purposes.
Exactly. Yeah. It's
Because you
much
don't have a
difficult.
chance to
Yeah.
do one case. So if I did for you one case directed to postural hypotension, I made you lose the chance to use your mind
Yeah.
to put all the differential because I gave you from outside hypotension. So I made your practice limited. But if I gave you dizziness and you had to prepare a full list, you are using your time better. You took one case, but as if you revised the whole dizziness scheme. So for practice online, I prefer the way Dr. Bassem or whoever is practicing with you, because you're doing one case in a week or two cases in a week, depend on how much you are participating. So it's better to do the cases in a difficult way, in like even though it's not similar to the exam, but
Yeah.
it helps. It
It's
helps.
it's like the hard level, and the exam will be either the middle
Easier for
or
you.
the easier. Yeah, hopefully. I don't think it will be vague like our presentation. It will be directed by some vitals, some data in the labs. So better
Even
to
the
do it in.
opening question, the answer of the
Yeah.
opening question, for example, usually you will find someone who is like experienced in PACES. When you ask him what brought you here, in the first two three lines he know how the transcript is written, and he don't want, and he know that your life should not be difficult, so he will give you extra symptoms and he will give you the posture and he will give you what he was doing, and this is real. This happened in the exam, but not everyone have such an experience in providing the information, and it depend on the exposure, how much real cases I get exposed to. So this depend on, but whatever is done is not bad. It will give you more
Yeah, yeah.
brainstorm.
Either
Not
this or that, it will
yes,
help. Yes.
it's not bad. Yeah.
But my real aim. Oh, I'm sorry, Dr. Bassam, continue.
Yeah, yeah. I mean, it help either by this way or the other way. Either you are helping the candidate in front of you, or you are just make it little bit difficult and let him struggle a bit, but he will be either reaching to the diagnosis and he will learn from this way or from the other way. Yeah, what you want to say?
No, no, it's what I wanted to say is to practice the common connections. Like for example, um,
We have
newly diabetes
we
and
had all of them in the YouTube channel, by the way.
yeah,
A lot of videos, a lot of cases, how we have practiced them, maybe one or more than 1 year. So you can find a lot of
mhm,
these the sessions, a lot of these diagnosed, newly diagnosed, the complicated one, the associated one. So don't worry, we mention all of them in the
yeah,
videos. Okay.
yeah.
Anyone else want to comment? Dr. Mahjoub didn't comment about this case.
I think the idea of the RCB, as I know,
Yeah.
they will give you just a sensible differential diagnosis. They want the one who will did the exam, he will give a sensible short differential diagnosis. Upon this, from the history, they want what support your diagnosis, the first
Exactly.
differential diagnosis, and the other point, what the question or to rule out the other differential diagnosis. Even if you did not reach the single diagnosis and you reach the three diagnose, for example, number one is most probable, and in your history you prove that you said this based on 1, 2, 3, 4, and you exclude the others two based on this 1, 2, 3 on history and examination, I think you will be on the safe side.
Yeah, perfect. Thank you, Dr. Mahjoub. Anyone else want to comment? Okay, I will read the comments quickly in the chat book. Dr. Tahani, differential hypercalcemia need to exclude lung cancer, multiple myeloma, and other cause of hypercalcemia. Hyperosmolar hyperglycemic, other metabolic cause like MI, brain insult, you can put it in the top, sorry, in the bottom of your lists. Why you mention MI? If you have evidence of chest pain, you can mention it, but otherwise, you cannot say. Brain insult, whenever you have a neurological deficit, you can mention. Otherwise, you can say against that. But the case, I think there is good differential, as we mentioned, the hypercalcemia itself, the HHS, and the constipation. All of them can be the reason. Even the infection. Multiple myeloma patients are having high suspicious to be having any infection. So you can mention any infection in elderly, like pneumonia, like UTI or urinary tract infection. HHS by Dr. Omar, yes, again, hypercalcemia, secondary. He had also hypercalcemia, paraproteinemia, venous thrombosis, perfect. But again, no neurological manifestation or deficit. There is neurological manifestation, which is confusion, but no lateralization. Okay. Need to rule out cord compression, Dr. Alicia, but how we can mention it as long as the patient doesn't have any weakness or peripheral signs of CNS manifestation, like weakness or pins and needles, or even the loss of control over the waterwork or back passage. The last comment, Dr. Ashiba again, lung cancer, squamous cell carcinoma is important differential associated with hypercalcemia either from bone mets or parathyroid hormone related peptide. If he's a smoker, you can put it as a strong differential. I think he's a smoker, so you can mention it. However, you have the multiple myeloma, makes sense.
But
Very good.
even
Yeah,
Dr. Bassem, the patient that doesn't have cough or any
exactly. No
difficult
chest
of breathing.
Yeah, so it's multiple myeloma rather than being squamous cell or lung cancer.
Yes.
Dr. Abdullah, very good idea. Can we put chat GPT inside, Dr. Okay, I will add this group to the community, and anyone interested, he can be added or put himself inside. Is there another case? No. Okay. Any other question or comments? Anyone want to add any comment before ending the session?
Thank you, Dr. Bassem.
Okay, thank you,
Thank you,
Dr.
Dr.
Abdullah,
Bassem.
Dr. Mahmoud, Dr. Omar, Dr. Hind, Dr. Mahjoub, everyone. I hope I didn't miss any of you. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa
Thank you,
rahmatullahi wa
thank you,
barakatuh.
Dr. Nasir. Thank you, everyone. Thank you, Dr. Omar, Dr. Mahmoud.
Most welcome. Most
Thank you,
welcome.
Dr.
Thank
Abdullah.
you, Dr.
Good
Abdullah.
night.
Thank you, Dr.
Good night, Dr. Omar. Good night.
Thank
Good
you,
night,
Dr.
Dr. Bassem.
Mahmoud. Salam.